Hi, my name is Chris Gregory, and I'm here to talk to you today about the LMA Supreme. This is a type of airway adjunct, and so what it's going to do is it's going to be able to help you as an EMT or a paramedic be able to get air past the pesky tongue and other occlusions that are posed by the airway and get air into the glottic space, just under the epiglottis, just where you're able to then either ventilate your patient with much more ease than with a BVM trying to get seal around the face, or if they're ventilating by themselves, allow them the ability to maintain their airway, especially if they're in a position where their airway could be compromised due to positioning or other factors. So we're going to be going through the skills used how to actually perform this LMA insertion, but also some of the things around the LMA. So we'll take a look at the history, we'll take a look at indications and contraindications. One thing though that we do want to kind of say beforehand is that this is not a BLS airway. This is going to be an advanced airway. And so what that means is that OPAs, the oropharyngeal airway, these are going to be, they need to be performed prior to the insertion of an LMA if this is a patient where the airway is compromised. So the LMA is essentially going to be an OPA but much more efficient. What that also means, once we start talking about indications and contraindications, the OPA, anytime it's indicated, that's when an LMA is to be indicated, which means also that the OPA should probably be inside of your patient's pharynx before you insert the LMA. NPAs are also going to be a great idea to use around this patient. However, the indication for an NPA would be that this patient is either semi-conscious or unresponsive. If they're unresponsive, LMA is indicated, but if they're semi-responsive, the LMA is contraindicated. But also, this is to be used for an unresponsive patient with a gag reflex. If our patient has a gag reflex, we may not use an LMA Supreme. That would also cause the patient to gag and potentially put vomitus in their airway and just not be a good situation. So OPAs have to be indicated, but they most likely will not be having an NPA in the patient yet. So this device was, it was kind of created in 1981 made by Dr. Archie Brain at the Royal London Hospital. And this device was created in an idea, in a way where it's going to be a better LMA situation, a better seal, and a better actually insertion than many other types of LMAs, or also than other types of supraglottic airway devices. Much easier to use than a combi tube because it only has one cuff to inflate. Also a better seal than an iGel because it has that cuff that's going to create a better seal with the pharynx. So this was a great device to be used, and it has a very high rate of success with the first try intubation. The LMA design, it's going to be situated itself just above, kind of at the upper esophageal sphincter. So actually it's going to be inserted into the esophagus, but it's going to provide this oval seal around the glottic space with that kind of area of the pharynx, so then air can go straight through into the glottic space, into the airway, but it's not itself going to be inserted into the airway. So we do not need a laryngoscope to be able to place this device, which is also great because that means that it can be within the BLS scope of practice. Some other things that I just want to kind of point out on this LMA here is that we have this cuff. So the cuff is what's going to inflate on the patient's airway. It also has a pilot balloon, which on the end of the cuff there's this tube that comes out, and that's how we are going to inflate it. But we can measure the pressure inside of the cuff by taking a look at the pressure within this pilot balloon. So that's another kind of piece that we'll see on there. This has a very rigid arch. So some LMAs, when you're inserting them, they have a pretty flimsy kind of actual bend neck to them. And as you're pushing them in, sometimes the tube folds, sometimes it doesn't go kind of as planned. This rigid arch, that's going to just mean that it's easier to insert and gets in the right space. We also have an integrated bite block in this device. So right where the teeth would be situated, right where those incisors will be situated, we have a bite block, which means that if this patient is having a seizure, an OPA would most likely get fractured with their teeth. They'll break the OPA off, then we'll have shards of plastic in their mouth. We don't want that. So the LMA actually can be used for a patient who is having a seizure or has some other kind of issue where they're biting down. Up here we have this fixation tab. So this tab is going to extend outwards, and that's going to be actually how we're going to hold this device in place. What that means is with something like an endotracheal tube, you're going to have to use either a commercial whole tube fixation kind of device, or you're going to have to MacGyver it with tape. But for this LMA, we have a built-in kind of fixation tab that we're just going to put a single piece of tape over and secure this device to the patient's face. Makes it great to actually insert. We also then are going to have two different channels going in. So this angled channel, this is going to be the channel that the BVM, if needed, will be connected into, and that's going to be the channel through which the patient is breathing. But we also have a vertical channel through here that goes all the way down and then actually out through the tip of the LMA, and this is a gastric channel, which means that's going to help us out with one of the tests that we're going to perform, but also if the patient needed to get food into their stomach or some other thing into their stomach, we could still use that gastric kind of pathway to put things into the esophagus. So that's kind of the situation of the LMA. If we take a look now at kind of when it's indicated, when it's contraindicated, and then some side effects, this is indicated anytime that an OPA is indicated. However, what it's going to be better for than an OPA is getting the seal. So if I'm using a BVM on my patient's face, any difficult situation for actually ventilating and maintaining the seal, an LMA will be an excellent candidate for that. One other thing that I can add too is that during CPR, using the American Heart Association's 2020 guidelines, with an OPA and a BVM, we're going to use a 30 compression to 2 ventilation ratio for adults or single rescuers on children, 15 to 2 with 2 rescuers on children. However, that means that we're going to have to pause compressions while we give a ventilation. Using this as an advanced airway, that now allows us to use the continual compression with a ventilation at 1 breath every 6 seconds for all patient populations. So that's just going to help us out a little bit getting the higher chest compression fraction. Again, a 10% increase in chest compression fraction represents approximately an 11% increase in ROSC. So that's awesome, and this device will help you get there. So another reason why this is an excellent device. If we take a look at the contraindications, however, there are a couple really important things that we just want to hit. In some counties, Santa Clara County in the Bay Area is an example of that, BLS providers are only able to use this device for adult patients. So make sure you check in with your local protocols to make sure you can use this device, but then also when you can. Additionally, if there's any edema or fluid within the airway, we want to stick away from this device. Patients with multiple injuries or massive kind of maxillofacial trauma, this will be manipulating their chin, their maxilla, and so we also would want to stay away from this device, preferring instead either that jaw thrust maneuver or if this is not a spinal patient, the head tilt chin lift position. So that's just something else we're looking at. And then finally, any patient at risk of aspiration. If we're considering them a fluid intake to their lungs or potentially also a vomiting patient, having this device in place with the patient vomiting would knock it aside, would potentially disrupt the seal, and it just wouldn't hold against vomit. And so we would rather kind of be able to tilt the patient onto their side and let them vomit out and also be aware of that vomit. One last thing that I want to point out are just some side effects of using the LMA. When this is inserted correctly, our patients might respond afterwards that they feel throat soreness or throat dryness. However, there should not be any soft tissue damage. However, if you do insert this incorrectly, then there is a possibility for other types of side effects due to the insertion. So now I want to take a look at this idea of pre-insertion and a specific thing we want to do before we put in any advanced airway, which will be pre-oxygenation. OPAs and NPAs, we're not going to pre-oxygenate, and actually we're going to do them during our primary assessment. These we're going to be doing during our secondary assessment. So our patients should already have the OPA inserted, but especially if we are ventilating the patient, if they're apneic, we cannot continue ventilating while we're inserting this device, and so there is going to necessitate a potentially up to 30-second pause, 30 seconds maximum of course, for this device to be inserted. We don't want our patient to go without oxygen for 30 seconds, kind of worst case scenario. And so what we would like to do is we'd like to take their lungs and we'd like to exchange the reserve volume. So again, that portion of the air that we aren't exhaling after every deep breath. And we want to change that from being 21% oxygen, 98% nitrogen, kind of everything else, to being 100% oxygen. How we achieve that is through pre-oxygenation. So we're doing this in 2 different ways, 2 different scenarios. If our patient is ventilating for themselves, if they're breathing naturally, no problem. We can go ahead and grab our non-rebreather mask, make sure to fill up the bag first, of course, and then we can place this over our patient. And then we will allow them to ventilate for themselves for approximately a minute. And the idea is every time they breathe in, they're pulling in about 85% oxygen. Every time they exhale, they're going to be releasing carbon dioxide, but also hopefully nitrogen. And then they're replacing that volume of nitrogen in their lungs with oxygen. So that's the goal if they're breathing for themselves. If they're not breathing for themselves, no problem. We can use our bag valve mask. However, we want to make sure to connect our bag valve mask onto oxygen. And then we want to be ventilating them just like normal, but for about a minute as well. And same idea there. A key point, though, is that with pre-oxygenation, we are not hyperventilating our patients. So we're not going to be ventilating them less than 1 breath every 6 seconds for adults. That would cause a decrease in carbon dioxide and a couple other things too. And so we'd rather just ventilate them like normal, but using a higher concentration of oxygen. For this, to do it, we're going to want to make sure that we get our patient ready as well. And so we want to make sure we insert our OPA. Again, I do it by tilting at a 90-degree angle. Once we reach the posterior of the tongue, we will twist it into place, making sure that that flange is not below the lips. We also want to make sure that the head is positioned in what we call a sniffing position. If we remember sniffing position from pediatrics, when they're in respiratory distress, they stick their head forward. Adults, we tripod. Pediatrics go into sniffing position. So the idea here is that your ears are going to be at about the level of your chest. I'm going to achieve that with this blanket placed carefully underneath my patient's head. So right here now, the ears are approximately at the level of the head. So from there, once we're in this position, we're going to connect our BVM into oxygen, and we're just going to ventilate. And in fact, I'm probably not going to do this. I'm going to let my partner do this. So then my partner can make sure that this patient is breathing while I get my other tools ready. So we want to wait for approximately 1 minute to 3 minutes while we're doing this before we try to insert that adjunct. So now if we take a look at the material. So my partner is getting this whole situation ready. I'm collecting my material. So we need a couple things. And I have several items scattered out on this desk here. First one is we need an LMA. We need that laryngeal mask airway. So for that, we're looking at patient weight in kilograms to determine the size. This one that I'm using today, this is a size 3. So this is going to be patients who are, let's see, 30 to 50 kilograms. A size 4 will be 50 to 70 kilograms. Size 5 is going to be anything greater than 70 kilograms. Additionally, on this size 3 packaging, it tells me right here that I'm going to need a syringe of air anything less than 30 milliliters. So I have a syringe right through here, and I can see on it, I can verify this is a 30 milliliter syringe. So that's great, that's excellent. I'm also going to need a stethoscope for this procedure. So make sure also that you're never holding your stethoscope around your neck, because that's a great way for your psychiatric patient to cause syringulation for you. So I'm going to place this just on the desk beside me. I'm definitely going to need my BSI, and I'll place those in just a second. I'm going to need a ventilation device, whether that is my non-rebreather mask if the patient is breathing spontaneously, or that bag valve mask if the patient is not breathing spontaneously. I'm also going to need suction, because I don't know what's going to happen with this patient if they start aspirating. I might find out the hard way that they have a gag reflex. I'm going to need some sort of fixation device. For the LMA Supreme, I just need a roll of tape. However, I could also potentially use a device, a fixation device, a commercial fixation device. That was what I was going for. I'm also going to need some lubrication. So I have on here some lubricating jelly from Medline. Do make sure that this is water-based lubrication for your patients. And then from there, if I'm working with a paramedic, I might need one of 2 items. So paramedics usually are required to have an end-tidal CO2 device attached in anytime that we're ventilating a patient. But they might also require a colorimetric device. We'll open this in just a second. So once I have all of those tools ready, my partner is still pre-oxygenating my patient, I can go ahead and put my BSI on. Now, it should probably have already happened, but for this procedure, I don't yet have it on, so I just want to make sure. Some other BSI that I would probably be interested in looking for, since this is an airway procedure, putting on goggles and a face mask. That would be recommended for this procedure as well, just because we don't want to get anything in our eyes. From there, once I have selected my appropriate LMA device, I'm going to go ahead and remove this red tab. This red tab is just pushing down on the valve to make sure that if we go up into altitude or traveling, that I can remove air or add in air in this cuff, so then we're not kind of accidentally pumping it en route to get to you. I'm then going to grab my syringe. I'm going to attach my syringe on just through pressing through that compression joint, and then I'm going to remove all the air in that cuff. So I'm going to deflate the cuff. For me, I'm going to go ahead and add in a little bit more air into the syringe just in case. So then from here, now, we're pretty much ready to go. I have my suction ready, I have my lubrication ready, my patient is being ventilated, so I'm going to go ahead and I'm going to get the LMA really ready to insert. I also want to point out that my patient is in the correct position, they're in that sniffing position. So I'm going to go ahead and open up my lubricating jelly packet. And I'm going to go ahead and apply this. I do not want an excess of lubrication. So I'm going to put a little bolus on the posterior portion, definitely on this arch. And then I'm just going to use my gloved finger to spread this out. So then it gets on the arch, but then also around the sides. So then that can really kind of help this get in. So I can place this around, but I don't want to leave like a bolus of lubrication on the tip. So once it's here, once it's lubricated, but there's not an excess, then I can go ahead and I can get ready to insert it. So on this, we have just finished our pre-insertion. We've just finished by lubricating. So now we can get into the insertion. So for the insertion, we want to make sure that our patient is in the correct position. Our partner, is ventilating our patient. So at this point, we can go ahead and have them step aside. We want to pull out the OPA using that anatomic position, pulling it just straight out and discarding this. And then we want to go ahead and get ourselves in the position at the head of our patient. We're going to grab the chin, grab that mandible, and we're going to pull this down. And then we're going to begin to advance the airway through the mouth. But we want to go ahead and make contact with that hard palate. And then we want to slide it in through that hard palate. At some point, once it's in the back of the mouth, we're going to start to feel resistance. This resistance is that we're getting pushing against the fascial pillars right through here. Fascial pillars is the posterior portion of your airway. It's kind of the narrowest portion of your mouth, right by your tonsils. That's not the end position for this LMA. So we're going to go ahead, we're going to continue through, we're going to push past, and at that point we can start rotating. As we rotate, we're going to feel definitive pressure when the LMA hits the upper esophageal sphincter. So it's not going into the trachea or the larynx, it's going into the esophagus, just that tip portion. And from there then, it's in the correct spot. That was it. We just slid it right in. But we don't yet want to inflate the cuff. We want to go ahead and grab our fixation device, which usually is just a piece of tape, and we want to go ahead and pull this out and just place this vertically down on that fixation tab that we talked about earlier, and then around the mouth. And one test that we can go ahead and do at this point is going to be called the tab test. We're looking at that fixation tab, and we're looking at the distance away from the upper lip. If the tab is greater than 1 inch, 2.5 centimeters, or if it's less than 1 centimeter, that's kind of what I use there, 1 inch to 1 centimeter. If it's outside of those dimensions, it's too big or too small. Remove it, grab a different size, try it again. But we want that tab to lie within 1 centimeter to 1 inch, so 1 to 2.5 centimeters above that upper lip. This is positioned perfectly. It's almost like I knew the size before I did this demo. So we can go ahead and we can move on to our next step. Now that it's in the position, we want to go ahead and inflate the cuff. So we're going to be using a syringe. I'm going to be adding in air, but I'm simultaneously feeling this pilot balloon. And I'm looking for it to be no greater than 60 centimeters of water. Okay, well, what is 60 centimeters of water? It's going to be about when it's rigid. So then we can go ahead and pull this off. And we do want to pull off the syringe because that locks this valve. So then it's not going to accidentally kind of push this, this plunger back up and reduce the seal. So from here now, we're good to go. So now we can go ahead and start embarking on some of our tests. If we're working with a paramedic though, they will require usually an end tidal CO2 device to be placed on, or also a colorimetric device. Colorimetric devices are usually not within the EMT scope of practice. This is a pediatrics colorimetric device, so it's a little bit smaller than you may be used to. But the idea here is that when air comes out from the lungs, it has a higher concentration of carbon dioxide. And we want to really measure that. Is there carbon dioxide within the lungs? And so what we're going to see is that when it comes out, this color should change compared to when we inhale. So on there, I don't have a picture of it up here, it's going to almost like pH paper or litmus paper. It'll be able to tell us the concentration of carbon dioxide or oxygen. If I'm ventilating, I'm pushing air in, it should be one color. If I go into the stomach, that air comes back out, it should stay that same color. But if it's coming out through the lungs, it should change between a nude color and a purple color. So that's what I'm looking for with this colorimetric device. If I'm just a BLS provider, I will probably not be using either of these airways. And so then I need to determine if my patient is breathing spontaneously or not. If they were breathing spontaneously, I can just stop here. If they were not breathing spontaneously, that's when I'm going to grab my BVM, but I'm going to remove the face mask section. I'm going to go ahead and attach this onto my partner, and my patient, and then I'm going to go ahead and begin ventilation. So when I begin ventilating, I should see that these two lungs are inflating, and on my patient they are indeed. And we're just going to continue ventilating like normal. So 1 breath every 6 seconds for an adult, every 2 to 3 seconds for a pediatric. So that's going to be how I can continue kind of ventilating for this patient. However, we do have a series of tests that we do want to perform as our partner is ventilating. Our first test we have already completed. This is the fixation tab test. So on this fixation tab sticking outside of our patient's airway, this should be between 1 to 2.5 centimeters, so 1 centimeter to 1 inch, if you think metric and imperial together, above the lip. If it's too high, again, too large of an airway adjunct, too low, too small. Just move sizes, try it again. So that's our first test, the fixation tab test. Use your clinical judgment there. Our next test that we're going to perform is the gel test. So we left off a little bit of our lubrication. And so what we're going to do is we're going to take some of this lubrication and we're going to place it into that gastric channel. So I'm placing that lubrication in. We just need to have just a little amount in there so then we can determine if any air is moving. If we're ventilating our patient and it's going into the lungs themselves, as I ventilate, there should be no movement of this gel. So there should not be air going out through my seal into the stomach and then back out through the gastric channel. If air is going into the stomach, though, what we're going to see is that that jelly will be kind of pushed out. I can actually demonstrate this. On this mannequin, I can grab into the stomach and I can squeeze. And what you're going to see is the gel coming out. So here I go, 3, 2, 1. And we can saw that gel got ejected. Not great, because that means that your LMA is not in the correct position. So most likely what you're going to need to do is you're going to need to connect your valve back on, decrease the pressure, manipulating around, make sure it's in the correct area, and then re-give it that pressure, or just make sure that it does have the correct seal. And then from here, try it again with some more jelly. So that's going to be our second test. That's going to be the gel test. If we move into our third test, and I have a couple on this slide here, our third test is that we're going to feel. We're going to feel around the actual LMA. Are we feeling any air coming out through the mouth? That would mean that we're letting air around the seal, around that cuff, and it's just coming out through the oropharynx or the nasopharynx. So I'm just going to be feeling around. Do I feel anything? Hopefully you should not feel anything. Which leaves us with our next test. We brought our stethoscope out for a reason. Let's go ahead and let's take a listen under the hood. We're going to listen to 7 places on the anterior trunk. Normally you listen to 6. You listen to the subclavicular, the parasternal, and then the subcostal down on either side. We're going to add in a 7th position, which is right over the stomach. Through here. We want to essentially see, do I hear anything? You shouldn't hear any air coming into the stomach and out. The stomach is for food and water, not for air. But if you do hear air coming into that stomach, that's just not going to be a great situation for you. So again, your seal is not great. Try again or use a different size. The last test that I have on this page is going to be, again, that colorimetric device. So we see when they inspire, we should see that that kind of litmus paper type thing is going to be a purple color. When they expire, it should change color to that nude color. And that's kind of how these devices work. And they just fit right onto your LMA, and then your BVM just hooks right in against them. And then as you're ventilating them, you should see kind of that difference. So those are the big tests that you are making every time that you are actually using this device. And so once you're able to kind of do this device, make sure that you practice this a couple times. Additionally, if you're a BLS provider and this is within your scope of practice, make sure you don't lose this skill. Make sure that you're constantly refreshing this skill or any other of the little used skills. I hope this helped you out with the LMA Supreme, and I look forward to seeing you on another video. Take care.